Welcome to the Mind Money Spectrum podcast, where your hosts, Aaron Ogti and Trishul Patel, go beyond traditional finance questions to help you explore how to use your money to achieve the freedom you want in life.
In this episode, Aaron and Trishul discuss the American healthcare system. Over the last generation, U.S. healthcare costs have more than doubled compared to other developed nations. But we are not any happier or healthier. So where does all this money go? How did we get to our current system? And how do we even shop around if there is no price transparency? They share some evidence and a few anecdotes to help illustrate how inefficient the current system is. In the end, they highlight a few programs to help individuals, and Trishul throws in an idea that could help raise GDP by 1%. And now, on to our conversation.
Hi, my name is Aaron Ogti. I'm a financial advisor in the Bay Area, and I'm here with Trishul Patel, a wealth manager on the East Coast.
Great to be here today, Aaron, and thanks everybody for listening.
Great to be here as well. Today, we're going to be talking about healthcare and specifically the costs. In the past, we have mentioned real estate, and last week we talked about college savings. And one of the things that we have observed and pointed out is that over the last generation or so, these costs have been increasing faster than inflation. Trisha pointed out that when it comes to real estate, the cost of housing has been going up as a percentage of household income and spending, and that may or may not make it a good investment moving forward. College's costs have been increasing faster than inflation, and so they have also become more expensive as a percentage of household income. It's no longer feasible to pay for college with your side job when you are in your late teens, early 20s. And it was a great point that it's probably not feasible for those items to continue to increase faster than inflation because they can't make up 100% of your household income. There has to be some kind of breaking point or leveling off or some kind of reduction. Or, as I pointed out, that a big reason they have been increasing faster than inflation and increasing as a greater percentage of household income and spending is because wages have tended to increase only with inflation. So real estate and cost of housing, both buying and renting, college savings, and also healthcare have been increasing faster than wages have been increasing. And today we just want to kind of explore some of the implications of that. And we're not political experts, and this part of the conversation might be hard to avoid some of the politics. We are not macroeconomic economists, but there are enough theories and ideas we've read, and I think that's the general theme for today. We just want to share some of the implications, some of the observations we've made, some of our theories and just flat out guesses, and see if you have any thoughts or opinions on what healthcare costs might look like in the future. So, Trishul, do you mind kind of giving us a good primer? What has been going on with healthcare over the last generation, and or what does it look like today, and what do you see moving forward? And I'll interject with a few questions when I see necessary.
Sounds good, Aaron. That was a great intro and a good primer to get the discussion going. To begin, something that we've noticed and something you just mentioned, Aaron, is that the percentages that families and us as a society spend on healthcare as a percentage of our total spending has increased quite a bit over the last generation or so. To put some numbers behind it, in 1970, the US was spending around 7% of GDP on healthcare. And today, or looking back, just a few years from where we have the latest data, 2017, for example, around 18% of our spending goes towards healthcare. So that's more than double. And again, the concern is it's just getting more and more expensive each year. And if this trend continues, you can imagine if it goes from 18% to like 30 or 40% over the next generation, and then 80% the next generation beyond that, it just starts getting a little silly. So something kind of has to give, but that's a big concern. Now, the other thing to kind of pair that against is what's been happening around the world. So around 1970, we were spending around the same amount as other countries, especially developed nations, on healthcare. But what has happened over the last 40 or so years is that the percentages that the US spends on healthcare has increased faster than many of these other countries.
Hmm.
So if you look today, for example, if we're spending around 18%, many of these other developed countries like Australia, Canada, Germany, Switzerland, UK, they're spending still closer to that 9 or 10% range. So on the one hand, we're spending more, but then we have to counter that with what are we really getting for that extra dollar? And if you look at some of the statistics on what we're getting, well, one thing you might look towards is a few things that we mentioned in the past. Are we more happier than these other countries? Well, no, we've looked at the World Happiness Index and we're not at the top. These other countries are above us. Are we living longer? No, that's not true either. So there might be some rationale behind this excess spending, but what it might come down to is we have a lot of bureaucracy in our system and a lot of overhead. And that might be a reason why we're spending so much and not getting so much out of the system. And kind of how that fits into the grand scheme of things is, you've probably heard this before, but we're the only developed nation on the planet that doesn't have a universal healthcare system. We have this conglomerate of public and private programs that split across different states with different levels of coverage based upon age, provided by different carriers, and so on. And what this ultimately leads to is a kind of mishmash of programs and options out there that are maybe ideal for a few, but leave a lot of holes in the works for many. So that's also something to think about. But that's kind of the big picture framework that we're looking at today. And then just kind of to put a dollar amount on it, we spend currently the most per capita on healthcare than any other country in the planet. On a dollar per dollar basis, we're spending more than any other country. And again, it's hard to say what tangible benefit we see for this excess spending. Some numbers that I have, again, from these are a few years old because it's hard to get data from every country, but from 2017, on a per capita basis, we're spending around $10,000 per individual per year. And the comparable country average is close to 5,000. These are developed nations, so it's about double. So that's something to think about. And this all comes down to, okay, that's the situation we're in, but now what?
So there are a couple other stories I wanted to add to that, kind of our country's history when it comes to health insurance. The first is, like you said, all the developed nations, they have a national healthcare system of some sort, but the US doesn't. Our healthcare system tends to be tied to employers, and the vast majority of people get their health insurance through their employer and through group plans. The reason this came about was that during World War II, for male workers, which was the dominant part of the workforce, who were not serving the military, the companies that were still here in the US, still at home, were trying to compete for those workers, and they started kind of trying to outbid each other. And the US government actually said, no, you're not allowed to try to outbid them for their services. And so you can't just pay them a higher salary. But one of the things that they were allowed to do was start to offer other benefits and perks. And so companies started offering health insurance as a benefit to attract those workers that were not serving the military. And the IRS also made it exempt from taxation. So starting about World War II, employers started using health insurance as the benefit it was designed, it's intended to be, as a kind of perk that's used to attract employers when you can't just match salary or can't outpace salary. Because prior to then, most people paid for their own health care out of pocket. So that was one thing that does make the US a little bit different in how we got to this primarily employer-based health insurance plan. The other is much more anecdotal. I've spoke to a friend who has finished medical school and he's been working as a doctor for a few years. And he was describing how all young doctors have really, really insane hours, that they're working so much and they tend to have high incomes, and they also kind of need those high incomes to pay off the very large student loans they incur from going to medical school. And I asked him, would his quality of life be a little bit better if he was working kind of normal working hours that most of corporate America works, so say 40 hours a week, but was making less? And he pointed out that actually is much more common around the globe, mostly because the costs of education are so much lower. Most other doctors internationally don't have as significant student debt from going to medical school, and they are willing to accept a slightly lower salary in exchange for better quality of life because they don't feel burdened by those huge student loan bills. But doctors in the US, because education is so expensive, they do feel more incentivized to work those extra hours to try and earn those high incomes to pay off those significant student loans. So those are two of the themes that I think about when looking at kind of costs of health insurance and why the US differs from the rest of the world. And I don't know how much of that is fixable, and I don't know how much of that is just kind of interrelated and just makes the US unique, but it does help provide context for how we got to where we are today.
I agree that context is important, and it's also a big differentiator on how we got here. I heard one news article from a legislator who said basically if we had to build the model from scratch, starting from a blank sheet, no politician or no sane human would come up with the system that we have today, just because it really doesn't make sense for the environment we're in. One analog to that is 40, 50 years ago, something that was very common were these retirement plans known as defined benefit plans. And the notion there is you go to, again, work for a company and they have these benefits where they'll take care of your retirement because you're going to be there for decades and they're going to pull the money together and invest it wisely. And when you retire, you get a defined benefit of a certain amount for the rest of your life. And issues with those types of plans are similar to what we're seeing with healthcare, where the amount that those plans need to keep going ended up going up and up in terms of keeping the cost sensible and the benefits in line with what people would expect when they first signed up for that plan. But the plans just couldn't keep up, and many of these plans ended up becoming insolvent. And it's similar with the healthcare side, where having an employer-sponsored plan maybe makes sense if you have a large company with a large pool of people to balance out the risks, and also people are staying with a firm over their lifetime, for example. But things are very different today, where you have individuals who bounce around every few years. You have individuals that might decide to be self-employed for a bit and then back into the employment marketplace a bit. And we have a lot of churning. So it's quite sensible for an individual, as we've mentioned in the past, to have many, many jobs across many different locations, across many different localities and so on over their working career. So a lot of the reasons why an employer-sponsored healthcare system that may have made sense in the past don't likely make sense today for some of these reasons. And the other main concern I'd bring up is it also puts in a big set of inefficiencies into the system, where now you have your employer somehow in the middle of your healthcare decision-making process. Whereas before, maybe you had, just yourself and the doctor, and then soon after that, you had yourself and the hospital and the doctor, and then soon after that, you had yourself, the hospital, the doctor, and the insurance company, and now you have yourself, the doctor, the hospital, the insurance company, and now your employer to all think about and balance in order to figure out what to do with your healthcare situation. So all of this adds just layers of complexity and I believe overall price. One thing that I found surprising, for example, is I was reading an article about just a standard hospital, and it was a good sized hospital. They had 100 beds. And then the question came up, okay, how many people in your billing department to get these 100 beds figured out in terms of who pays what? Well, the hospital had 1,000 people in their billing department just to figure out who gets paid on these 100 beds. So for each bed, you had 10 people with full-time salaries just to figure out who gets what dollar amount for whatever happens in that bed. And you can imagine that's just the hospital side. Now you have a team of people at the insurance company side to figure out how little to pay the hospital and then how little to cover you. So now you need somebody to help you out to navigate this whole mess. So I believe a lot of this just adds extra overhead into the system, where it seems like a cleaner solution should be more sensible.
I think I saw an article recently that there are maybe 10 times the number of healthcare administrators as there are doctors at any particular hospital location. And this is a very broad catch-all. So doctors is specific to medical doctors. This excludes other caregiving staff, such as nurses or respiratory therapists, etc. And the hospital administrators is just basically anyone who's not involved with the giving care to a patient. So this would include secretaries, people from the billing department, and also the management and executives of the hospital. But I was shocked, and I had to question and see, and I'll try and find that add to the show notes. But yeah, 10 times more hospital administrators than doctors. And that's probably where a lot of the costs are going.
Right. You can imagine why we're paying double if we're spending all of this just to figure out how much to charge for a Tylenol. And you've probably seen those crazy articles where, a bag of saline ends up being charged at $100 when it's really should be less than $1. And all of these nonsensical things that somebody needs to go on just to find out how much their procedure would cost if they want to try to shop around, which you're not going to do if your hand is chopped off and you're running around the city looking for a doctor. So a lot of these things just don't seem to make sense in terms of the situation we're in. And what it kind of leads to as well is we have this notion that if somebody gets sick, they will get some sort of care, but it happens to be the worst, most inefficient way possible, meaning, okay, somebody has a cold and they have nowhere to go to. Where do they go? They go to the ER.
Yeah.
The most expensive place you could send somebody, just because we don't have any other options. And that ends up increasing the cost, not for just that hospital, but for everybody. Because the government says you have to take that person in, even though it's the silliest way to go about it. In fact, over 40% of ER patients are there just because they have no other option. Mm-hmm. And again, it feels like that's the right thing to do because we don't have any better solution, but it doesn't mean that we can't come up with something better, because it seems like most of the planet already has.
Yeah, yeah. The other anecdotal story, but it's fairly representative. In the Bay Area, in San Francisco, there's the Zuckerberg Chan Hospital. The Mark Zuckerberg and his wife, I forget her first name. I believe she's also a doctor. They created a hospital that was designed to be an elite trauma facility and was going to offer help to all the uninsured. That was kind of the goal of the hospital. And one of the things that came about of that, there was a story of a woman who was riding her bike and was hit by a car. And she was concussed. I don't think she lost consciousness, but she definitely was able to make decisions. Ambulance took her to the nearest trauma facility, which was this particular hospital. But she did have insurance through her employer. So because she had insurance, the hospital said, you're not uninsured. We're not going to pay for this from our general fund. They're going to bill the insurance. But this hospital was out of network for her employer's insurance. And so they also weren't going to pay. So she was concussed and unable to make a decision for herself, did not have a choice in the emergency room the ambulance took her to, and ended up with a $50,000 ER bill because neither the hospital nor the insurance company would cover because it didn't satisfy the particular requirements. And this might be a sensationalized story. I do believe it did happen and might just be a one-time case, but this theme comes up all the time. And I've actually dealt with it several times in the last few years, where when you go to the ER, even if you go to the in-network ER and your copay is $100, the doctor that sees you, which you don't have a choice of, just they take you to a back room and the doctor comes in and provides care, the doctor may not be in network. And so then the doctor bills you directly because the insurance company says they're not covering that particular doctor. That happens all the time.
Yeah, it's kind of scary, even though it sounds silly, because I don't think it's just a few people who are facing this. It's something that I've mentioned before. The number one reason why people go bankrupt in this country is not because of these other reasons, it's because of healthcare bills.
Mm-hmm.
And the majority of these people have insurance. So I find it really hard to argue that the system is working pretty well. I find it hard to see that these inefficiencies are something that are sensible and by design acceptable. It's one of those things where I do think it makes sense to have a free market and have a system where the market can come up with prices, but it's tricky to do that if you're passed out and concussed. It's tricky to do that even if you're not, because you don't know which doctor is going to show up, like you said, in the ER. So it's one of those situations where it's so hard to let price discovery happen, which is the key to having an efficient market, when prices are so opaque. And I think that's the situation we find ourselves in. And that's the reality of what I think we have to accept.
Related to that, and this is kind of how I personally apply all the things I like about capitalism to health insurance and medical costs. This is a story I got there. Like, when a patient is having a conversation with a doctor, neither of them are involved in the payment decision, like how that care gets paid. And so when it's just the patient and the doctor, they can have a quality of life and or best of care conversation. But if neither is even considering the cost, that natural incentive is just to go with the best and most expensive thing. And I do wonder how often other people around the world can incorporate that cost into that decision-making process. And the kind of two questions are, one, can they? And two, should they? This ends up becoming, it's not usually not a case for someone younger, but it tends to be for things like end-of-life care, where a doctor and an older patient who may not have a terminal illness, but their health is going down, maybe it is a terminal illness, and a lot of times it is cancer related, they can do this procedure or this thing that can maybe extend their life a year, maybe only as little as 3 or 4 months, could be as long as 2 to 5 years, but it's hard to really know. And the conversation is going to be about the quality of life aspect. Do they want to go that longer? They may not be aware that this could cost on the scale of $100,000 to $1 million. Neither of them are involved in that part. But if you gave the patient that choice, would you rather try to extend your life a year or have $500,000 for your beneficiaries, kind of whatever that cost of care is? And it's not a direct comparison because you're not going to pay that $500,000 out of pocket. And so it's a system-wide cost savings, but there would be some savings that might get left over. But would that change the patient's decision-making process? Would it change that calculus?
It's a very good question because the current way that things are set up, you can't even figure out the cost, even if you try to dig into it. And you probably won't find out until months after because nobody really knows until all of the dust settles and the insurance company gets billed and they push back and the hospital tries to bill you for some, and then you talk to the insurance company and you all do this rodeo for a couple of months. And then finally some money gets settled in these different pockets of different individuals within the system. So it's even hard to even solicit costs if you tried to upfront, let alone the silliness of even being able to do so in times of duress. And also some of those cost benefits are hard to weigh because they require a good amount of understanding of pretty complex topics. So expecting an individual to dig into the nuances of neurosurgery or the benefits of lifetime therapy across many different pharmaceuticals, it just seems very challenging for somebody who is probably already in some stress to begin with.
So it does sound like you and I would most likely agree, but you made these really good comparisons to the systems of other developed countries. Do you have any idea what those tend to cost at the individual household level?
Well, so I have it on a per capita level, and that's some of the numbers I put out before. So the 217 numbers, these are PPP adjusted, meaning they tried to come up with a parity amount across different countries, accounting for different rates of inflation and whatnot. So for the US, I have $10,000 per capita. And for the average comparable company in this set, which includes Switzerland, Germany, Sweden, Australia, Netherlands, France, Canada, Belgium, Japan, Australia, and UK, the average cost is $5,200. So that's where I got we're paying about double per head in terms of getting coverage or just healthcare spending. And what that means is maybe we're living a lot longer and we're a lot happier, or there's some sort of tangible benefit for these extra expenses. But it's hard to say where all of this money is going beyond a lot of overhead and a lot of inefficiencies in the system.
So now I'm wondering, when it came to real estate, you could actually choose where you live. You had a little more control. For college, you also have a little bit more control. You can just take out the student loans. You can choose to go to a cheaper college. You can choose to go to community college. You have some impact. You can also save up in advance for that. For healthcare, what are some of the actions that individuals can take?
Right. So the common action, as you had mentioned, that most people go with is they go with their employer-sponsored plan. And the decision is simple because you already get it through your employer. The drawbacks are, what if your doctor isn't in the network? And also, it sounds like it's free, but technically that's coming out of your salary, meaning if the employer didn't pay for that, they'd be paying you more. It's not like they're giving it out of their pocket or their lunch money. It's coming from somewhere, and likely it's coming from your paycheck.
Yeah.
So that's the status quo. And there are other options as well, but the way it works is we all know there are these ACA plans out there, the Affordable Care Act plans, which you can get through healthcare.gov. And these plans are actually pretty good because they are very robust. They allow you to have pre-existing conditions. And they also come with a government subsidy if you qualify for them, which can lower your healthcare monthly premiums by a good amount. What that means is if you make less than, I think it's like 80 or 90,000, you'll start getting the subsidy, and that subsidy grows if you're below a certain amount.
Okay.
And that's probably your best option if you have a pre-existing condition. But it turns out if you have an employer plan and that works for you, that's fine. If not, you can get one of these plans if you have a pre-existing condition. But if not, and you don't qualify for a subsidy, these plans can get pretty pricey. My wife and I priced out a plan, for example, and it wasn't a Cadillac plan by any means, but it was around $960 a month with a total max out of pocket of around $14,000 a year. And what that basically meant is it had a very high deductible, meaning it didn't really provide coverage until that deductible of $8,000 was met. And then beyond that, it would only pay a certain percentage up till that $13,500 amount. That's what an ACA plan will get you. But if you have a pre-existing condition, that's probably your best bet at this point, because if you try to go for a private plan, either they just won't give it to you or the amount that they'll charge will be quite astronomical.
Yeah. You said $960 for that was for the two of you?
Yeah, for my wife and I.
That sounds on the scale of something I've helped some of my clients with. There's been a few cases where they will be in their early 60s, maybe in the scale of 60 to 62, and they would like to retire. And the only reason one of them is still working is for healthcare costs, is for the health insurance that their employer provides. So once the Affordable Care Act was passed, we were able to start actually doing the math. And instead of waiting until age 65, when Medicare starts, they looked at, can we afford these really high monthly premiums for a few years? So they were on a scale of $1,100 per month to $1,300 per month. So we're spending $13,000 or $14,000 per year to cover this, but it was for a finite number of years, from say age 62 to age 65. Another option for those that wanted to retire, didn't want to have the employer-based plan, but weren't old enough for Medicare, was using COBRA. So this is now where you get the same insurance coverage that you had through your employer. This is a federal law, but now you have to pay the entire cost. So like what you said, the employer has some health insurance cost that they pay out, but it's probably, like you said, your salary would have been higher if they weren't. Now you are absorbing those entire costs, and it's usually on the same scale. It's usually something like $1,100 to $1,300 per month. Right? That's how much your employer has been paying for your health insurance already. Being in California, there's also a related plan of CalCobra. That's a state-specific plan. So COBRA provides an additional 18 months of coverage. It's designed to act as a gap from when you leave one employer and move to the next employer, that you don't have to be uninsured for during that gap. And you can't actually backdate COBRA. So you don't have to decide when you leave. You can say, okay, something happened before my new job started. I can backdate COBRA. You do have to pay $1,000+ It could be even more expensive for families. I've seen some of the family costs if you have 2 or 3 kids on a scale of $1,500 to $2,000 per month. It's kind of thing that you normally wouldn't pay, but if you had that medical emergency before your new plan started, you at least have that option. So that can provide coverage for 18 months. CalCobra provides coverage for an additional 18 months. So it is possible for some California residents to retire 3 years before 65. So retire when they're 62. They can pay for these really expensive CalCobra and Cobra costs until Medicare starts. And Medicare premiums are usually on the scale of $120 to $180. I usually assume a $200 future cost, then maybe another $150 to $300 for Part D and a few other additional parts that tend to kind of get the different levels of coverage. So it's almost always on the scale of $200 to $500 per month per person in Medicare. And when that sounds like it's right in line with those international numbers you described of you're going to pay between $2,400 and $6,000 per year, depending on the level of coverage you want. And most people are paying right around $400 or $500 a month, which would be right around that $4,800 to $6,000 per year, which seems to be a reasonable cost of care.
Well, to be clear, though, that cost of care that I mentioned is for the in total care, not just the premiums. Meaning, even though you spend $5,000-6,000 on premiums, you may have to still spend a lot more if you actually need to use your insurance.
True. I would say if they're paying that $500 per month, the costs out of pocket tend to be much, much lower because they're already including most of the things. If they're paying the $200 a month, they definitely will have some costs out of pocket. So you end up getting things like glasses and hearing aids that may or may not be covered. They could be covered for the more expensive plans. They're less likely to be covered for the cheaper monthly premiums. But it would not surprise me if the average total cost, both premiums plus out-of-pocket costs, were on the scale of $5,000 to $7,000 per household, or sorry, per individual, not necessarily per household.
Yeah, so the recommendation that I see is if you can, try to go for these plans where, Medicare, Medicaid, and there's a program for kids called CHIP, if possible. But if not, they are those ACA plans if you don't have employer sponsored. But the other option is you can get private insurance that's not ACA compatible, and the prices can be lower, but the thing to watch out for is that, for example, if you have a pre-existing condition, you may not be allowed on those types of plans. If then that might be a good option. If you are healthy and in good condition and no major illnesses for the past X number of years, you could get a private plan that's lower, assuming you don't have a pre-existing condition, for example. So that's something to think about.
So they do have an application process.
They do have an application process, and they may ask more questions to confirm your health, and they may even require you to have, just some more tests or some more information sent about your health history that ACA application would not look into. So it's something to consider if you're looking to lower your coverage amount or lower your premiums, that is. And the other thing to consider is a short-term insurance plan. So with that, these plans typically range from 6 months to a year, and then you have to renew again. But the notion there is it's meant to be a bridge between the time where either you're going to be self-employed for some time, you're switching jobs, you're on sabbatical, something like that. And the goal there is to cover you until you can jump on another employer-sponsored plan or until open enrollment begins for the following year for ACA. the Affordable Care Act plans. With these short-term health insurance plans, these short-term medical plans, there are a few cautions that I would put up there. There are these plans that are called fixed indemnity plans, which I recommend avoiding at all costs. These are plans where they look very cheap. If you search for them, they can look almost silly cheap. But what they're actually doing is, even though they say they provide a couple 100,000 of coverage, they have a limited amount of coverage per each incident. So for example, they may only cover you for $1,000 per day if you're in a hospital and things like that. And the concern there is a hospital can charge quite easily a lot more than 1,000 a day, and that would leave you hanging, especially if something major happens. So I would say short-term plans are sensible, but definitely avoid any short-term plans that are fixed indemnity plans. These are also known as mini-med plans. So again, try to avoid these two if you're going with a short-term plan. You want a short-term plan that doesn't try to list out all the benefits and provide a cap on each of those different concerns that could come up. But you want a plan that has a high overall benefit amount that doesn't try to list everything out. And this might help you, for example, cover a gap for a short period. And then let's say something does happen that is unfortunate, that requires a more robust plan. Well, then at the end of the current year, you can try to hop on a ACA plan for the following year, which will be required to accept you because they allow a pre-existing condition. So that's an option that you might consider if you want to go this route for the short term.
That actually reminds me of looking at the pricing of accidental death and dismemberment insurance. So AD&D insurance that is a very common group employer benefit. That there's a normal group life insurance cost, and then you see that AD&D cost, and it's fractionally smaller. It's, like you said, almost ridiculous how cheap it is. And it's because you're significantly less likely to die from an accident or something that insurance would actually cover than you are from a disease, health issue, etc. And anytime you see these types of insurance that seem really, really cheap and only pay out under these certain circumstances, those were probably ones to avoid. I know there's been like cancer insurance in the past that will pay the cost if you suffer from cancer. It's like, well, the odds of your health issue being cancer are so much lower than what that insurance company is kind of receiving in premiums and paying out. Like, insurance companies, if they're going to do this, they're going to make sure they're profitable from that perspective. And those tend to be the ones to avoid. You want the insurance plan that will cover all the situations because you can't predict what your specific situation is going to be.
Right. And those little costs add up. For example, I was pricing out a plan this morning by just calling one of these short-term insurance companies, and I didn't ask for anything in particular. I just said my wife and I need coverage, and the first price that they came back with was something around $350 a month. And I'm like, oh, great, that sounds good. And then the insurance specialist started to go through the things that were included with that. And I always tend to go for something with a high deductible. It's something we discussed in our last episode where if you have a lower deductible, you end up paying a lot more in premiums. If you go with the high deductible, you can lower those premiums. And what I like to do is take the difference between how much I would pay between those two premium choices and just kind of self-insure that way myself. And so I went with the $12,000 premium, but then including in this plan were these various caveats where included an extra $50 a month if I accidentally couldn't go to work, if I ended up in the hospital, if I broke my left toe, if my ear was hurting, and so on. So subtracting all of these away, it actually reduced my premium from that $300 a month to around $190 a month, just by taking away these kind of things that would only help me in certain special silly situations. So the actual base insurance that would just cover me after my deductible is all I really wanted, and that was only $200 a month. So compare that to the 950 that I started with the ACA plan if I had a pre-existing condition. This, for me, might not be a bad option for the rest of the year, for example.
Okay. So I think that's the key. Like, it only covers you for that year.
Right. Yeah.
Okay.
Now, the scary thing with insurance these days anyway is if you're not going with an employer-sponsored plan, you probably need to shop around every year just to make sure. So you have to, again, this is another inefficiency, but you have to become an insurance expert for a day, figure out what's the best solution for your case. I even did some quick math. If you're an insurance expert for a day and you're spending another day fighting the insurance company, figuring out bills over the course of a given year, that's 2 days of lost work for every individual in the US. That would probably bump up GDP by another % if we could eliminate that hassle. So, it's hard to raise GDP growth from 2 to 3%, but this might be a quick solution if anybody's listening.
That's a really interesting argument that I have not heard any kind of politician or economist try to make, that reducing the time spent dealing with healthcare and insurance can raise GDP.
It's a real cost that I think that gets overlooked, where you have really these random bills coming at various times.
Yep.
And it's your job to figure out whether X amount is covered properly or was there a medical error. Obviously, for 1 day in the hospital, it requires 10 people for the hospital and maybe another 10 people for the insurance company. Well, that's going to take some of your time as well to navigate. So that, again, in my mind, it's just wasted bureaucracy.
Yeah. So if you were in charge of everything, what are some of the things that you would implement? What is your dream?
It's unfortunate that we have to worry about our health situation, even if we have insurance, and we have to worry what happens if we change jobs or if we want to retire a few years early. And it's annoying that you even have all that, and then we end up paying double. It just kind of makes me a bit angry.
So you'd actually be okay. You'd be okay paying double if it was significantly easier and took care of everything.
And you live longer, and
and you were happier.
You had some benefits, and you were the happiest nation on the planet, which we are if you don't look at the numbers. So I'm sure we can look towards the evidence to see what solutions are better. I'd say that's what I'd say. I'm sure we're not the first people to try to figure out insurance, and I'm sure there have been other models out there that we could think about a lot more concretely. And I'm sure it can be studied. For example, Massachusetts actually did implement in 2006 a form of universal healthcare for that state. That might be an example of a state that's tried it, and we can see how that's worked. And we can try other pilot programs and let the evidence drive what makes sense. So I think that's what I'd advocate for, rather than jumping to a particular notion right off the bat.
Okay, that's interesting. Well, I don't want to say I was avoiding this topic because I knew I'd feel frustrated by all the things, like you said, we've seen other countries do this. We have models to follow, and I don't feel optimistic that we'll ever get there, or at least not in the next generation, just because there's too many polarization and political issues related to it.
Yeah, probably. We've seen a few solutions peek through the cracks, which I am happy about. Something that's probably useful now these days with COVID is the notion of telemedicine, where you don't need to go to a doctor's office, sit in a room with a bunch of other sick people for an hour to tell you that, oh, you have a fever, it's a virus. By the way, we can't do anything, but you can take a Tylenol to control it and come back in a week if symptoms don't get better. So I think things like that will be helpful. There's this notion of travel medicine where it's cheaper to fly to another country to get your bypass and have a 2-week vacation, even if you have insurance in this country. So
I think I've seen stories of insurance companies paying for you to fly to Mexico, and they will fly your doctor to Mexico to use the Mexican hospital to perform your surgery, and they'll give you some money out of pocket because it costs them so much less.
Right. So maybe there are price pressures of this sort that will help things out. I don't see a short-term solution either, but I have seen other systems work in other countries. For example, when I was in Malaysia for a couple of years, I had a private plan, although they do have a public system there as well. It was almost silly what my premiums that my employer was paying were, but it was 200-300 a year for my wife and I in premiums. But the crazy part is, I used to walk to work. It was a walking city that I lived in. And there was a medical clinic on the way, a private medical clinic. And if I broke a toenail, I would stop in and see the doctor and he would help me out. So I just felt a sense of comfort knowing that if I wanted to see a medical professional, I could hop in and see one at any time without worrying about costs, something that I wouldn't dare to do here unless I was on life support. So I've seen systems work better. I was even in Hong Kong a few years ago, stopping by, and my daughter got sick. She had the flu, and we had to see a public hospital. And in all honesty, I haven't seen a better run hospital in the States than the one I went to, where we were in and out in an hour. We got our medication there, and the bill was like $20. I was floored because the service and the representation we saw was what I would expect for the US, but I don't think I've seen that level of service here, to be honest.
Okay, well, I'd like to end on that high note. That actually made me feel good. So
there is hope, and things will get better over time. I'm optimistic on that.
Well, thank you much for all the information you provided today, Trishul. I definitely learned something new, and I really appreciate it.
Thanks, Aaron. This was a fun one as well. And thanks, everybody, for listening. And of course, if you like what you're hearing, do let us know or send us a comment or leave a comment. Thanks, Aaron.
Thanks. Bye.
Bye.
We appreciate you joining us today for this episode of the Mind Money Spectrum podcast. Be sure to visit mindmoneyspectrum.com to access the entire library of episodes. Remember, it's not black and white, but the wide spectrum of gray area where you get to pursue the freedoms you want in life. Opinions voiced in this material are for general information only and are not intended to provide specific advice or recommendations for any individual. All performance referenced is historical and is no guarantee of future results. All indices are unmanaged and may not be invested in directly. Have a nice day.